This is session 7 of the maternal shock and maternal collapse, and this session is part of the 12 session course, which is totally free. It's just concerned with fighting for maternal lives. This session we will be discussing fluids and blood components before we go into the session 8, which is the resuscitation. I want to remind you that during this course we had 6 sessions before. We finished the maternal emergency and the maternal shock and collapse, and then we had the definition, physiology, pathophysiology, all this stuff. And then we had a separate session, continuation of session 2, which is the obstetric patient. This was a very important session. And then session 3 was the causes of maternal shock and maternal collapse. And then session 4, the clinical evaluation. Session 5 was the monitoring. Session 6 was the most important session in this lecture. Session 6 is the treatment of shock. And from now on, session 7, session 8, when we talk about resuscitation, this is no treatment of shock. This is just helping the patient to survive while I am treating the cause. And this is a very important tool in winning your fight for maternal life, is that you remain focused, you remain concerned with your objective. The objective is to treat shock, not to resuscitate the patient. Resuscitation is just helping the patient to survive while I'm focusing and I am performing the treatment, which is treatment of the cause and not resuscitation. Concerning fluids and blood components, first of all, what fluids do we have? We have crystalloids and we have colloids. Crystalloids, we have the D5 water, and the D5 water we will not be using at all in any shocked patient, because D5 water is just dextrose and water. Dextrose is an intracellular molecule, not an extracellular molecule. So what happens is that when you give it, the dextrose will enter the cells, taking with it the water component, and so you are actually aggravating the hypovolemia. The ones we will use is the normal saline or the Ringer lactate, and we say or, so it means that both of them are very similar in statistics concerning success and patients' survival. However, some research claims that Ringer lactate or the Hartmann solution is better in the management of shock than normal saline. The precaution is, because the start of this lecture we said that we may do faults during resuscitation which will actually deteriorate the patient's condition. This is the first fault. Crystalloids, you never give more than 2 liters. Never give more than 2 liters. Every 3 liters crystalloid will add to the intravascular volume 1 liter. But I will never give 3 liters. So I cannot expand the intravascular volume more than 2 liters crystalloid, which 2000 milliliters. So this means that only 1/3 of them will be present in the circulation, which is about 700 cc's. So this is the maximum I'll give from crystalloids. Why? We said this when we discussed physiology. The massive transfusion or the aggressive fluid transfusion, which is 3:1, is prohibited. Of course, because it may pop up the blood clots that have been formed, but more importantly is that this is fluid, this is not blood. This has no oxygen carrying capacity. So actually what you are doing is that you are losing blood and you are giving fluids, and so you are adding to tissue hypoxia. Remember when we talked about viscosity, you give fluids and you don't give blood. What will happen is that the hemoglobin percent will decrease and the tissue hypoxia will be aggravated. Also, there is a chance that you will create a coagulopathy, because fluids only increases coagulopathy by diluting the clotting factors. So coagulopathy will be aggravated. And they found that mortality for patients who are not given fluids is much better than patients who are given more than 2 liters crystalloids. Okay then, maybe we give colloids. Colloids are plasma expanders. Colloids, they expand the intravascular volume 1:1. In my experience, I always avoided colloids, so I don't use colloids. However, I will tell you the guidelines. I'm telling you my experience and I'm telling you the guidelines. The guidelines say that if up you gave 2 liters of crystalloids and still no blood is available for replacement, then you can give colloids up to 1.5 liter colloids in addition to the 2 liters crystalloids. So the maximum fluid you can give is 3.5 liters. Maximum 2 liters crystalloids, maximum 1.5 liter colloids. Why I'm not a fan of colloids? Because colloids, we have 3 things. We have the albumin, we have the hypertonic saline dextran, and we have the hydroxyethyl starch products. The hydroxyethyl starch products are prohibited by the guidelines. The guidelines, the RCOG, recommends against using any hydroxyethyl starch product because it may cause renal failure and it may lead to patient mortality. So it increases mortality, and that's why we will not use them. So we are left with the albumin and the hypertonic saline dextran. All of the colloids, by the way, they lead to coagulopathy. All of the colloids increase coagulopathy. So whatever type I will say, it increases coagulopathy. Albumin is better avoided because albumin actually carries, or most of the substances in the blood, or most of the substances that we give like medications or whatever are bound to albumin. So if you give albumin, you will actually bind many of the endogenous products that the body produces in order to combat the shock state and to fight the shock state, and may also bind the drugs that I'm giving in order to help the patient survive shock.
All lectures are based on Tocqueville textbook, your one-stop, postgraduate study source, and decision support platform. You have 14-day free full access trial. Follow the link in the description to start your trial. Remember to hit the subscribe button, and if you find this video useful, please like and share.
That's why albumin may have potentially marked effects on the normal homeostasis and metabolism and on drug delivery and efficacy. The second thing is that albumin is a weak acid. So if you give albumin, you are increasing the acidity. If the body actually went into hypoalbuminemia in order to decrease the acidity and increase the bicarbonate concentration. If you are giving albumin, you are decreasing the bicarbonate concentration, and so the buffer ability of the body to combat acidosis is decreased. The third thing is that albumin, as all colloids, have anticoagulant effect, and thus it may induce coagulopathy. Albumin can change the microvasculature of the small vessels, and we know little about this. We know little about the microvasculature and the cellular mechanism. Many textbooks refer to shock as the known unknown. It's that we know that we don't know. So we don't know a lot about microvasculature, and so allowing albumin to alter the microvasculature and use its antioxidant and anti-inflammatory effects and anti-apoptotic effects may alter the response of the patient to shock. So most guidelines will tell you, okay, you want to give albumin, fine, but it's not recommended. So we will stick to the word, it's better avoided. And then the hypertonic saline dextran combinations, these also are better avoided. These molecules, we have the dextran 40 and the dextran 70 and the dextran 110. And this refers to the molecular weight. So what we use in shock is the large molecular weight dextrans, which will stay in the circulation. So we use dextran 70 or dextran 110. We don't use dextran 40. The problem, I think you heard dextran before. You know where? In the management of maternal anemia, the IV iron dextran. And we said then that it should be avoided because of the severe anaphylaxis it may induce. So again here, a dextran molecule may lead to anaphylaxis and anaphylactic shock. Also, it is excreted unchanged by the kidney. So it creates a load on the kidney, and sometimes it will lead to renal failure. That's why dextran is not used. It is contraindicated in any renal disease. It can expand the circulation, so in heart failure or in risk of pulmonary edema, we don't give dextran. And because of the coagulopathy it may induce, as all colloids, it is not given in a bleeding patient. So what does this leave us? It leaves us albumin, which is better avoided, dextran, which is better avoided because of coagulopathy and because of the renal affection and because of the anaphylaxis, which is pretty dangerous, it can kill the patient. And we said that hydroxyethyl starch products should not be used and contraindicated, better avoided by RCUG guidelines. It should not be used, so this leaves us with crystalloids only. And the main transfusion we aim at is the blood transfusion. So after settling the dilemma of fluids, we'll go to the blood. Now the blood components are formed from the whole blood a donor gives. The donor gives whole blood, and then this blood is spent, it's centrifugated, and it will result in separation of the whole blood into three partitions. One of them is the packed RBCs, which will give you a bag about 250-300 milliliters, and the plasma. And in the middle, the plasma is also volume expander, it's about 250 milliliters, which is a good volume. And in the middle there is a layer, which is the buffy coat. The buffy coat is the layer which contains platelets and white blood cells. So this means that the plasma, fresh frozen plasma, will have all clotting factors except the platelets, which are in the buffy coat. If you centrifuge the plasma, after thawing, it will separate into a cryoprecipitate and a cryopore plasma. The cryoprecipitate has factors fibrinogen, von Willebrand factor, and you put the V with the W, it will give you factor 8, and if you extend the V lines, it will give you factor 13. So the cryoprecipitate has fibrinogen, von Willebrand factor, factor 8, and factor 13. The cryopore plasma has the rest of the clotting factors. The factors which are not affected by cold. These are factors 2, factor 7, factors 9, and factor 10. And these factors are sold as human coagulation factor concentration in ampoules like this. What we use in shock is the cryoprecipitate because I sometimes am in desperate need to fibrinogen. The buffy coat, on the other hand, has very little platelets. So we take the buffy coat from many donors. This means that we have a pooling first. We pool the buffy coats from several donors, 4 to 6 donors, and then after pooling we spin the buffy coat and get the plasma concentrate. So the plasma concentrate is 50 milliliters compared to the cryoprecipitate, which is 15 milliliters. And of course the platelet concentrate is full of platelets. Okay, so these are the blood products that we can use. We can use fresh frozen plasma with all clotting factors, coagulation factors, and with fibrinogen. Or we may use cryoprecipitate for fibrinogen concentration, or we may use platelet concentrate for platelets, and the star of the party is the packed RBCs. What we give is, we never give whole blood. We never give whole blood. If you give whole blood, this will deteriorate the patient. So this is the second mistake. So the first thing we said, we don't give more than 2 liters crystalloids. We better avoid colloids, and we don't give whole blood because whole blood is deficient in clotting factors. Whole blood has high potassium, high ammonia, and high hydrogen ions. Hydrogen ions means that this whole blood can lead to acidity because acid is hydrogen ions. And it can cause volume expansion while I don't have clotting factors. I need to give plasma. But if you give plasma, even 250 mils or 500 milliliters, you will end up with pulmonary edema because you already replenished or you already replaced the volume loss. So sometimes you reach your maximum volume of transfusion before replenishing the blood products. Okay? So we don't give whole blood. What we give? We will give, first of all, transfusion. There are not two methods. No. There are 2 objectives of transfusion. First objective is, I am doing volume replacement. If you are doing volume replacement, you do not rely at all on lab results, on laboratory. You rely on 2 things. You rely on the patient's general condition, a patient's condition, which may deceive you. And you rely on the assessment of the amount of blood lost. And we, as obstetricians, we always underestimate the blood loss. We always underestimate the blood loss. So try always to correctly estimate how much blood loss is there. And don't be deceived. A patient with no change in the vital data, and this patient is pale and bleeding, she's bleeding, there is a shock eliciting event. Even if you don't see the bleeding, you don't visualize it by your own eyes. But this patient, you know she's bleeding, and this patient became pale. This means that this patient at least needs 1 liter, at least, because 1,000 milliliters can be lost before the patient suffers any tachycardia. If you have tachycardia, this means that at least you need 1 to 1.5 liters. And then you go with the clinical assessment, as we said, in order not to be deceived. Now for volume replacement, if the volume lost is heroic, is 3 liters or more, then you use the massive transfusion protocol. So it's not like everybody replaces with whatever he wants. No, it's not like this. There are preset protocols that we have to transfuse respecting these protocols. The first protocol is when you need massive transfusion. The patient needs more than or equal to 3 liters. You give 6 units packed RBCs with 4 units fresh frozen plasma, 1 unit platelet concentrate. This is 1 unit of transfusion, 641. And if you need another 3 liters, you give the 3 liters with the same divisions. You give 641, 6 packed RBCs, 4 fresh frozen plasma, 1 platelet concentrate. The other transfusion preset protocol is the RCUG. 4 units blood, 4 units packed RBCs. If I say blood, I mean packed RBCs. We never give blood. So you give 4 units packed RBCs, 4 units fresh frozen plasma. You need more, 4 units packed RBCs, 4 fresh frozen plasma. The 1 unit will give you 2 liters because packed RBCs, 300 times 4, that's 1.2. And then you have about 0.8 to 1 liter fresh frozen plasma. So this gives you 2 liters and a quarter, 2 liters and a half. So you give 2 liters like this. If you need less, you are a smart physician and you diagnose the patient very early. So you just need to balance before the patient goes into pallor or tachycardia or anything. Then we give 4 units packed RBCs, 1 unit fresh frozen plasma. And then if we need to give more, then for every unit packed RBC, you give 1 unit fresh frozen plasma. So you give, and this also can apply if you don't have enough fresh frozen plasma. If you don't have in the blood bank, they are not ready to provide you with 4 units for the 4 units packed RBCs. So you give 4 packed RBCs, you give 1 fresh frozen plasma. And then for every 1 unit packed RBCs, you give 1 unit fresh frozen plasma afterwards. As we said, don't give whole blood because it's deficient clotting factors. So this is as if we are reuniting the whole blood, but the plasma here has the clotting factors because it's fresh frozen plasma, frozen. So the objective here is volume replacement, and the objective volume replacement is not achieved by lab-guided transfusion. After we restore the volume of the patient and we have treated the cause and everything is fine, now we do the fine-tuning. Now we will do the lab-adjusted or the lab-guided transfusion. The lab-guided transfusion has objectives. I need hemoglobin more than 8 grams per cent or hematocrit more than 25%. I need PT, PTT-INR less than 1.5 normal, and we talked about PT, PTT-INR before. And I need platelets more than 75,000 and fibrinogen more than 200 milligrams. So these are the 4 components that I'm concerned with: the hemoglobin, the clotting factors, the platelets, the fibrinogen. How can I achieve this? For hemoglobin, you give packed RBCs. How much? Every 1 unit packed RBC will elevate the hemoglobin percent by 1 gram and will elevate the hematocrit by 3%. If you need clotting factors, then you must know that every 1 unit for 25 kilogram of the patient will increase clotting factors by 25%. So fresh frozen plasma, every 1 unit fresh frozen plasma per 25 kilogram of patient's weight will increase the clotting factors by 25%. So for example, if the patient is 100 kilograms, then you need 4 units of fresh frozen plasma in order to elevate the clotting factors by 25%. And here I want to remind you again, that's why we don't give whole blood, because if you give whole blood, you will reach volume load, which is, say, break-even volume load. You are balanced before you replenish the clotting factors. Now, if the patient bleeds, you need to give 1 liter of plasma. How can you give 1 liter for a patient who is already loaded? You will go into volume overload and you will go into pulmonary edema. Now for platelets. Every 1 unit platelet concentrate per 10 kilogram of patient's weight will increase the platelets between 20,000 to 50,000. So if the patient is, for example, let's go with 100 kilograms, this means that I need 10 units. The unit is 50 milliliters, so I need 500 milliliters of platelet concentrate. Fibrinogen, this is the least of them because it's 15 milliliter the unit, and every 1 unit cryoprecipitate for every 10 kilograms of the patient's weight will increase the fibrinogen by 50 to 100 milligram percent. So maybe you need 1 or 2 transfusions maximum. And then after you start the lab guided transfusion, your lab guided, so you will request your lab and re-examine the results again, and give again, and re-examine the results, till you replenish all the blood components that the patient lost. So this is the lab-guided protocol. This is not another protocol. No. It's something else. It has nothing to do with volume replacement. You cannot do volume replacement lab-guided. Volume replacement is by clinical assessment and by estimation of the blood loss. The lab guided is to replenish. This is the second step. So this is a second step in the replacement, effective replacement in a shocked patient. Now we have to know when and how to use the blood products, because there is a risk of bacterial contamination, loss of function in blood products, and this may lead to transfusion reactions. So what we have to know is that RBCs, you start transfusion within 30 minutes of taking them out of the refrigerator, and you have to complete the transfusion within 4 hours. For all other blood products, you start transfusion as soon as possible or immediately, and you have to complete the transfusion within 30 minutes. The second thing is that you have to monitor the patient during transfusion. You have to take the basic data, the baseline observations of the patient, and then 15 minutes after starting transfusion, at least every hour during transfusion, and carry out a final observation 15 minutes after you finish the transfusion. And of course, the best way to monitor a critically ill patient is the MEOW score, the modified early obstetric warning score that we said, we talked about it before in monitoring of a shocked patient. You have to document transfusion, and documentation, you have to document everything. The patient, the blood bag, the blood group, the unique serial number of the blood bag. All this has to be documented, and then the time you start transfusion, the time transfusion ended, and who was responsible for the transfusion. So this is basic. I just want to stress on this, that you have to start transfusion of any blood component bag immediately, and it has to finish within 30 minutes. The blood itself, you have to transfuse within 30 minutes of getting it out of the refrigerator. You have to start the transfusion, and it has to be completed within 4 hours. So now this is what I wanted to say about the blood transfusion. Now about the blood, the fluid. So this is what I wanted to say about the fluid and blood components. Now the next session is very important, session 8. This is the resuscitation, and I will explain it as treatment cards. And if there is a critically ill patient, you just have a look at the card, and when you look at the card, you know what to do. This is the focused resuscitation. Okay? So this is next session, which is session 8. Thank you.